Okay, let's unpack this. Abdominal pain in children.
Mm-hmm.
It's incredibly common, right? Causes so much worry for kids, for
Yeah.
parents. But what's really going on when a child says their tummy hurts?
Yeah.
Is it always something serious? Or, are there other things happening?
That's exactly it. And for this deep dive, we've got this great set of sources, clinical guidelines actually, focused specifically on abdominal pain in kids aged 4 to 16.
Okay.
And our mission really is to cut through the noise, pull out the most important bits from these guidelines,
Right.
help you understand the different ways this pain shows up, how doctors approach figuring it out, and this is key, the best ways to manage it, especially when, the standard tests don't show a clear physical cause.
So we're basically navigating these clinical maps together, highlighting the key takeaways, maybe challenging some assumptions people have.
Exactly, giving you a clearer picture of what might be going on with those belly aches.
Let's dive in then.
Okay, so the guidelines, they give us a really crucial starting point. They define abdominal pain based on two main things.
Two main things.
Yeah. How long it lasts, the duration, and what seems to be causing it.
Okay, duration first. That makes sense.
Precisely. It shapes how doctors initially think. So you've got acute pain that's new, lasts a week or less. Then non-acute pain, which is over a week, but not quite chronic yet.
Got it.
And finally, chronic or recurrent pain. The definition here is pain at least once a week for 2 months or longer. That time frame, that distinction, is really the first fork in the road.
And the second thing, the cause.
Right, the cause. Broadly, the guidelines split it into pain with a somatic cause.
Meaning like a physical thing. Infection, inflammation.
Exactly. Something you can usually measure or see in infection, inflammation, maybe an anatomical issue. And the other category is functional pain.
Functional pain. Okay, this seems like a really big concept in these sources.
It is. It's probably the most critical and maybe the most surprising for a lot of people. It's defined as abdominal pain, where, the standard workup history, physical exam, maybe some initial tests, doesn't find any underlying tissue damage or a physical condition or metabolic issue that explains it.
So it's not saying the pain isn't real. The guidelines are clear on that, right?
Absolutely not. The child is feeling pain. It's just that the usual suspects, those physical diseases, they aren't found.
Okay.
And that's why the focus shifts depending on duration. Acute pain, you're really focused on diagnosis, ruling out serious somatic stuff.
Makes sense.
But once it becomes chronic and you've kind of ruled those things out, the focus shifts much more towards understanding and managing this functional pain.
Okay, so how common is this? Are we talking like a rare thing or something doctors see pretty often?
The sources give us some numbers. They say around 8% of kids in the general population have abdominal pain regularly.
Wow, 8%. That's
Wow.
quite a lot of kids.
It is. And if you look at a typical GP practice, they might see, say, 11 to 14 kids with abdominal pain each year.
Okay.
But here's the really interesting part. The guidelines state that in primary care, something like 2/3.
2/3.
Yeah, roughly 2/3 of these cases turn out to be pain without a clear somatic cause. So falling into functional pain or constipation.
Huh.
And there's a note that girls tend to report this functional pain and go to the doctor for it more often than boys.
Interesting. So, okay, a child comes in, bellyache, especially if it's acute, new pain.
Yeah.
How do doctors start figuring it out? Sounds like finding those serious physical things is priority one.
Exactly right. With acute pain, especially if it's the first time, the assumption has to be, well, it could be somatic until proven otherwise.
Okay.
So the very first step is looking for what the sources call alarm symptoms. Red flags, basically. Things that shout, hey, something potentially serious needs urgent attention.
Red flags. Okay,
Yeah.
let's break those down. What are the signs that need immediate, like right now, attention?
The guidelines are specific here. Immediate assessment is needed for severe, debilitating pain, if the child looks really unwell, if they're vomiting blood or green fluid that's bilious vomiting, or if they seem drowsy, lethargic.
Okay, those sound serious, urgent.
Definitely urgent. Then there are signs needing same-day assessment, things like rectal bleeding, having a fever along with the pain, or persistent vomiting that just won't stop. These are the key things doctors are trained to spot right away.
Got it. Immediate and same-day flags. What about other clues? Maybe not life-threatening right now, but still pointing towards a physical cause.
Yeah, there's a whole list of indicators from the child's history and the sources. Things like a recent injury to the abdomen, persistent diarrhea, which might suggest certain infections, pain or burning when peeing, or peeing a lot that points towards a UTI.
Okay.
For teens, obviously, issues related to periods or potential pregnancy. Then there are other patterns, like a rash and joint pain happening together could be something like Hanauschenlein purpura, or recurrent fevers with the pain, especially in kids with specific backgrounds like Mediterranean or Middle Eastern might suggest familial Mediterranean fever.
Okay.
Also really important is family history, things like celiac disease or inflammatory bowel disease, IBD, and then general signs, unexplained weight loss, poor growth, delayed puberty, or symptoms outside the gut that are linked to IBD, like certain skin rashes or eye problems.
Wow, that's a comprehensive history check.
Yeah.
What about the physical exam itself? What are doctors actually looking for when they examine the child?
The physical exam is absolutely crucial. It's not just, pressing on the tummy randomly.
Right.
Doctors observe the child's overall behavior. How are they acting? Are they listless? Then a careful abdominal exam, checking for specific tender spots, any swelling, unusual firmness, what they call guarding, or signs of peritoneal irritation.
Peritoneal irritation, what's that?
That suggests inflammation might be spreading inside the abdomen. They might also feel for a large mass if they suspect severe constipation. And for chronic pain, they'll always check growth height, weight, BMI, and look for those other signs outside the gut we mentioned.
So history and exam give the clues, which brings us to testing. That's what parents often wonder about, right?
Yeah.
Does my kid need a bunch of tests for these belly aches?
Yeah, and this is one of the most, I think, surprising and important takeaways from these guidelines, especially regarding functional pain. They're very specific and maybe not what you'd expect.
How so?
Well, if the history and exam do strongly suggest a specific physical cause like appendicitis or a UTI, then yes, you do targeted tests.
Makes sense.
For example, suspected appendicitis, they recommend a urine test to rule out a UTI because symptoms can overlap. But interestingly, they specifically say routine blood tests like CRP for inflammation or white blood cell counts are not generally recommended in primary care for suspected appendicitis.
Really? Why not?
Their value in that setting just isn't clear enough, according to the evidence reviewed. And feces tests for parasites. Maybe, but only if the child has had diarrhea for more than 10 days straight.
Okay, so targeted testing if signs point that way. But what if, and this seems common, the history and exam don't show any red flags or strong signs of a physical problem?
This is where the guidelines have a really clear, strong message. Limit additional testing.
Limit it.
Yes. If there are no alarm symptoms, no indicators of a somatic cause from a good history and physical, the recommendation is to only do a urine test to rule out a UTI.
Wow. Just a urine test. That feels minimal. It goes against that instinct to test for everything, just in case.
It really does. And the guidelines are firm. They explicitly list tests that are not recommended in this situation.
Like what?
Routine blood tests for celiac disease, unless there's a strong family history or clinical signs, obviously. Tests for H. pylori bacteria. Routine allergy testing or lactose intolerance tests. Feces tests for various bugs like Giardia, Dientamoeba, Yersinia, Campylobacter, unless there's significant persistent diarrhea associated with it.
So why are they so strongly against more testing in those cases?
The thinking, based on the research these guidelines looked at, seems to be that without specific clues, these tests are very unlikely to find a physical cause.
Okay.
And they can lead down a rabbit hole, unnecessary anxiety for everyone, more invasive tests, maybe even finding something incidental that leads to a misdiagnosis or unneeded treatment. The focus shifts because the likely mechanism isn't structural or infectious, it's functional.
Okay, so let's talk about that. Functional pain. If the physical causes are ruled out, what does that actually mean? What's happening? Is it, just stress?
That's the million-dollar question, isn't it? And the sources explain it using what I call the biopsychosocial model.
Biopsychosocial, okay.
Yeah, it means chronic pain isn't just physical or just psychological. It's this complex interaction between biological factors, how the body's systems are working psychological factors, like emotions, thoughts, coping styles, and social factors, family, school, friends.
So it's definitely not just stress, but stress is part of the picture.
Exactly. Stress and other psychosocial factors play a really significant role. The most accepted explanation for how this works is the brain-gut axis.
The brain-gut axis. I've heard that term.
Think of it like a super sophisticated two-way communication highway running between the brain and the entire digestive system.
A gut-brain highway.
Okay, I like that.
It regulates everything. Gut movement, sensitivity, how the gut sends signals back to the brain. Now, in kids with functional pain, the idea is that there are disruptions along this highway. the gut can become hypersensitive.
Hypersensitive. Meaning?
Meaning normal things like food moving through or a bit of gas, which wouldn't bother most people, get perceived as painful. The volume is turned up, essentially.
Okay.
And here's where the psychosocial part connects directly. Things like stress, anxiety, difficult experiences, they can actually influence the signals on this brain-gut highway. They can amplify the sensitivity, making the pain feel worse or happen more often.
So the stress isn't just making them think they hurt more, it's actually changing the physical signaling in their gut. That's the core concept behind the brain-gut model in functional pain. It's a real physical manifestation mediated by this complex communication system.
Wow.
The sources also briefly mention, though it's less studied in kids than adults, a potential link between a history of abuse and functional GI issues later on.
Right.
The exact mechanism isn't fully mapped out, but it fits within this broader biopsychosocial idea, significant life stressors impacting physical health through pathways like the brain-gut axis.
Understanding that mechanism helps frame it differently.
Mm-hmm.
But what about the long run? For kids with chronic functional pain, what's the prognosis? Do they just outgrow it eventually?
Well, the sources discuss this, particularly for kids seen by specialists. They suggest the pain can stick around for several years in about 1/3 of cases.
1/3. So for a decent number of kids, it can be quite persistent.
Yes, while many do improve, for a significant group, it can be a longer-term challenge.
Are there things that make a child more likely to develop this kind of pain or for it to keep going? Risk factors?
Yes, the guidelines do point to some risk factors. Things like anxiety or depressive symptoms in the parent seem to play a role.
In the parents. Interesting.
Yeah. Also, if the child, or sometimes the mother, has multiple other functional complaints like frequent headaches, sleep problems, limb pains, alongside the tummy pain.
Okay.
For pain that keeps going specifically in the primary care setting, the research is a bit thinner, but one factor mentioned is if parents have their own chronic gut issues or if they are strongly, persistently pushing for more and more tests even after initial findings are normal.
Mm-hmm.
And the guidelines also note there seems to be a link between having chronic abdominal pain in childhood and then developing irritable bowel syndrome, or IBS, as an adult, especially if there are other psychosocial issues going on too.
Okay, so this brings us back to management. If tests are limited, medication isn't usually the answer, and it's this functional brain-gut thing. How do you help a child manage this day-to-day? What's the approach?
This is where the guidelines offer really practical advice. The absolute foundation, the cornerstone of managing functional abdominal pain, according to these sources, it's built on good communication, providing clear information, and offering reassurance.
Reassurance, just confirming it's not something dangerous.
Exactly that. For many children and parents, simply hearing that a thorough check has been done and no serious underlying disease was found is incredibly powerful. It often leads to a noticeable improvement in symptoms just by itself.
Wow.
And then psychoeducation. This is seen as indispensable.
Explaining the why.
Yes, explaining the multifactorial nature. It's biological, psychological, social. Explaining the pain is real, but not harmful. Explaining the brain-gut link, how stress or emotions can influence it. It helps everyone understand what's going on and gives them a framework.
It shifts the focus, doesn't it? From what's broken inside me to, okay, how do we handle this?
Precisely. And the goals of treatment need to be realistic. The guidelines emphasize aiming for a decrease in pain frequency or severity and improving the child's quality of life, getting them back to school, activities, not necessarily aiming for zero pain ever again, which might not be achievable.
Getting back to normal life, like school, is part of the solution, not something to avoid because of the pain.
Absolutely. Encouraging normal activities is seen as vital for recovery. Now, here's something really interesting, maybe even counterintuitive, that the research highlights.
Go on.
The way parents react to the pain seems to actually influence how severe it is.
Wait, really?
The research suggests that giving the pain a lot of attention, constantly asking, "How's your tummy?" expressing a lot of worry, can sometimes unintentionally reinforce the pain signals or increase the perceived severity. But on the flip side, distracting the child when they mention the pain, that's been shown to potentially reduce the pain intensity by as much as 50%.
50% reduction just through distraction. That's huge. But telling a worried parent to not focus on their child's pain, that sounds incredibly difficult.
It is completely counterintuitive, I agree. The advice isn't to ignore the child or dismiss their pain. It's about gently shifting the focus of the interaction.
Okay.
So instead of constant questioning about the pain, the sources suggest parents try to focus more on positive interactions, talking about things that are going well, encouraging fun activities. It's about changing the response pattern to avoid inadvertently amplifying the pain experience.
That's a really powerful insight for parents.
Yeah.
Okay, what about other things people often try? Diet changes,
Right.
supplements.
Yeah, the guidelines looked at the evidence for those, and they are quite clear. There's currently insufficient evidence to recommend things like adding extra dietary fiber, trying lactose-free diets routinely, or giving probiotics specifically for treating functional abdominal pain in kids.
Okay, so those aren't standard recommendations based on current evidence.
Ah.
And medication, we touched on this, but just to be clear, no standard pain pills or antacids.
Generally, no. The sources state that common medications, standard pain relievers, antacids, even things sometimes tried like antispasmodics or certain antidepressants, are largely not considered helpful for functional abdominal pain due to a lack of strong evidence showing they work effectively in these specific cases.
Right.
Laxatives are different. They're only used if the child actually meets the criteria for constipation, which is treated as a separate issue, even if symptoms overlap with functional pain.
So non-medication strategies are really front and center. Was anything else mentioned?
Yes, finally, they touch on psychological interventions. Things like relaxation techniques, cognitive behavioral therapy, CBT, and even hypnotherapy.
Do those help?
The evidence quality varies a bit for specific techniques, or it might be limited, but the overall picture is that psychological approaches do seem to have positive effects. They can help reduce the severity and frequency of chronic functional pain, often with relatively short courses of therapy.
Okay, that makes sense within the biopsychosocial model.
Yeah.
So putting it all together, understanding the types of pain, the approach to testing, the focus on functional pain, and these non-medication strategies, when is it time to go beyond the primary care doctor? When should parents seek a referral to a specialist?
The sources outline several clear situations for referral. First, immediate referral to a surgeon for what's called an acute abdomen. Severe pain with signs of peritonitis, that internal inflammation, or a possible bowel obstruction. That needs urgent surgical assessment.
Okay, that's clear.
Then, referral to a pediatrician or a pediatric gastroenterologist is needed if the history and exam strongly suggest a specific somatic disease, like IBD or celiac disease, especially with those positive family histories or clinical signs.
Right.
Also, referral is indicated for unexplained weight loss, significant growth delay, or those extraintestinal symptoms we talked about.
Yeah.
For functional pain itself, if it's severe, persistent, and not getting better with the primary care approaches, then consulting with a pediatrician is reasonable. They might consider if any subtle somatic causes were missed or help explore more specialized psychological treatments like CBT or hypnotherapy.
Makes sense.
And one final really important point the guidelines make. Child abuse should always be considered as a possibility with chronic, unexplained complaints. If there's any suspicion, consultation with Child Protective Services is necessary.
That's a critical reminder. So reflecting on all this, gosh, it feels like the world of kids' belly aches is way more complex than just looking for a bug or, something obviously broken.
It really is.
These guidelines seem to shift the whole perspective, really highlighting that connection between the gut and the brain, how our experiences, our environment, aren't just in our heads. They can physically manifest as pain.
Absolutely. It takes functional pain from just being, well, we don't know what it is, a diagnosis of exclusion, to being a condition with its own understandable mechanisms, rooted in that brain-gut axis and influenced by all these other biopsychosocial factors.
And knowing that simple things, reassurance, explaining what's going on, encouraging normal life, are actually the core treatments rather than just tests and pills. And even that, how a parent reacts, can subtly nudge the pain levels. That changes the whole approach, doesn't it?
It really does. It's less about finding a single cure and more about managing a complex interaction. It really underscores the power of that mind-body connection, especially in childhood, and the need for a holistic view.
So what does this all mean for you, listening, maybe as a parent or caring for a child with tummy troubles? If this functional pain can stick around for years in about a third of kids, and it's so tied into brain-gut sensitivity and psychosocial factors, what does that suggest about maybe shifting focus toward long-term coping skills, building resilience, supporting the child's overall emotional well-being alongside the medical side? Even if the pain doesn't vanish completely, it's certainly a lot to think about.